Hi everyone, welcome to Hub Bites. I'm Sanil, Rege, consultant psychiatrist. Today I'll be talking about 12 essential skills for a psychiatrist. Now, this might be relevant for those of you wanting to do psychiatry, or you're probably already a psychiatrist and you might be interested in knowing what are some of the skill sets for a psychiatrist overall. I'd also be interested in your insights as to what additional skills beyond what I'm going to talk about might be relevant. So if you have any thoughts, please do put them down in the comments section. So let's get started with the 12 essential skills. Firstly, the ability to accept failure. In psychiatry, you're more likely to be wrong than right. It's not as dichotomous in a sense of wrong and right, but I guess the point I'm trying to make is that the process of diagnosis is iterative, which means that initially we might gather a few facts, we create a hypothesis, and that hypothesis can be disproven later on because additional facts come on board. So this is a really humbling field where our hypotheses can be constantly challenged and disproven, and it's something that we accept and we change with time. We also recognize the importance of second opinions, because what we're trying to do is to constantly falsify our hypotheses, because we know once we exclude the impossible, what must remain is as close to the truth as possible, just as Sherlock Holmes said. This also links to Daniel Kahneman's System 1 and System 2 thinking. System 1 thinking is the fast thinking, which is the heuristics. We jump to that, we see a certain group of symptoms and we jump to conclusions. But the System 2 thinking is the really important, careful thinking that attempts to falsify that hypothesis. So therefore we search for evidence to tell us what are the kind of things that tell us this might not be the diagnosis, and we do this simultaneously. So it's a great field because of this intellectual stimulation as well. For example, I might have a patient in front of me who presents with low mood, anhedonia, amotivation, guilt, worthlessness, suicidality. Now, if I jump to System 1 thinking, I might say that's depression because they fulfill criteria. But at the same time, my System 2 thinking kicks in and says, hold on, let's take a medical history. And in the medical history, if the patient tells me, well, I have a family history of dementia, Parkinson's, specifically frontotemporal dementia, I'm having urinary incontinence, the age of the individual is 55. You see, what's happening here is that a primary diagnosis of depression may be disproven because this could be an organic depression, because frontotemporal dementia, for example, can present like that. So it just gives you an idea about our hypotheses are constantly challenged. And as a psychiatrist, we've got to learn to sit with that uncertainty and accept failure. 2, dealing with uncertainty. Overall, we know that humans change, and therefore the ability to make decisions with change becomes extremely important. We're constantly dealt with changing situations, changing desires of the individual, the carers, the family members, and we've got to adapt at all times, of course, keeping the patient's best interest at the center. 3rd, delaying gratification, and the ability to know that much of the reward, the pleasure about work takes time. The reason is because a lot of psychiatric treatment takes time. Even in the initial stages, we know antidepressants can take 2 to 4 weeks to really start acting. And that's just the biological part. We've got to think about the psychological part and the social part, and then the recovery, the long-term aspects, which is really the relapse prevention. We're on a journey with the patient for decades, and we're thinking long-term. So therefore, gratification may be delayed, and there are times when that might be ruptured and we say the patient's relapsed, and we start again and we try to bring the patient back towards that recovery again. 4th, always thinking in terms of probabilities, a risk-benefit analysis. We're constantly weighing up whether our treatment proposition, the benefits outweigh the risks, because that's when we fulfill the ethical domain of beneficence, acting in the best interest of the patient. If the risks outweigh the benefits, then we're more likely to withhold that treatment and tell the patient and the families about that. So it's all about probabilistic thinking, and we know that thinking in terms of probabilities means that we're constantly weighing up options which can change over time as well, which links to that uncertainty. 5th, communication and negotiation skills. This includes empathy. And the communication and negotiation skills are of course, with the patients as well, when we're trying to apply the principles of influencing them or persuading them to take the treatment that might help them when they possibly do not have insight because they've lost insight due to the illness. We remember the principles of influence: reciprocity, liking bias, authority bias, scarcity bias. We've got to constantly in negotiation think about compromises, and this negotiation might happen with other individuals, our nursing team members, psychologists, other medical professionals, etc. So we're constantly applying these principles of negotiation, influencing, and persuasion. 6, the ability to unlearn in the face of evidence. So the initial hypothesis changes. This is the iterative thinking that I talked about. We're constantly attempting to falsify our hypothesis, and we are comfortable unlearning in the face of new evidence. 7, getting along with people. And I think the best book for this was How to Make Friends and Influence Them. I think that was a book. It's a great book to read, all the principles around them. And this is about mutual respect for the people that we meet, understanding the roles, the responsibility, respecting everyone's role within the overall treatment milieu for the patient, respecting patient's wishes, respecting family wishes, etc. People, dealings, management, collaboration is crucial. Next, the ability to get a broad overview after getting the facts of the case. And this is that bird's eye view thinking, because we're constantly thinking in terms of formulation. So we think about factors and we think about how that applies to causality. And we think about causality very, very differently. We think about biological plausibility in one direction. We think about reverse causality. We think about confounders. We think about the possibility that this might just be a coincidental link. So we're constantly thinking about the factors of the case, and we develop a formulation from a biopsychosociocultural diet lifestyle perspective, a really holistic way of thinking. Next, having a strong base of medicine. Henry Miller, the neurologist, described it best. Psychiatry is nothing but neurology without the physical science and requires diagnostic virtuosity of the highest order. And it also links to William Osler. There are no true specialties in medicine, since to fully know most of the diseases, one must be familiar with the manifestations in all organs. And this applies to psychiatry because there isn't a mind-body dichotomy. There's no Cartesian dualism. The mind and the body are linked. And what we find in psychiatry is that we see prodromal conditions. We see conditions where patients might have been told that this is actually a psychiatric condition. I did a video on serendipity and multidisciplinary learning where I've highlighted a case of someone who was referred to me, had seen several specialists, and was diagnosed with conversion disorder and functional neurological disorder. But ultimately, we were able to work with a hematologist and diagnose antiphospholipid syndrome, and she's well, completely. The seizures stopped, did not have conversion disorder. And this is not an isolated incident. Take, for example, anti-NMDA encephalitis. 75% of anti-NMDA encephalitis actually presents to psychiatrists first. The form Frust group, which is the prodromal one without the neurological manifestations, might still be within psychiatric settings. So we are really dealt with medical issues, and we need to be really, really good in medicine overall. Take, for example, thyroid dysfunction, thyroid autoimmunity, polycystic ovarian syndrome, understanding of the hormones. Because when we think about the brain, the organ with the highest number of thyroid receptors is the brain. We have estrogen, progesterone playing a very, very important role in the brain. So we truly, as psychiatrists, need to think about medicine across all specialties and work collaboratively with our medical colleagues. Furthermore, we also think about pharmacokinetics. We think about how conditions such as epilepsy, for example, the bidirectional, the tridirectional, multidirectional causality. For example, if I have a patient with epilepsy, the temporal lobe epilepsy may be mimicking psychiatric symptoms, because temporal lobe epilepsy can associate with psychotic symptoms, depression, etc. But on the other hand, reverse causality, they might be prescribed anti-epileptics such as levetiracetam that can increase the risk of psychiatric disorders. Furthermore, they might be prescribed antidepressants or antipsychotic medication that can lower the seizure threshold, which can further worsen things. Then we have something known as forced normalization, where the normalization of the EEG can actually unmask psychotic symptoms. Then I've got to think about confounding variables. Is there intellectual disability present? Is there an autoimmune condition present? Head injury, etc. Because these can be associated with both exposure and can influence the outcome, a true confounder. Finally, there might just be a coincidental link that epilepsy and psychosis might exist independently. So you can see how the thinking occurs. We think from a multi-directional perspective, and developing that skill is crucial. Then thinking outside the box. And this is where I talked about epilepsy and psychosis. I just sort of covered it in terms of causality. We always think outside the box in terms of multi-directional influences. 11, short-term thinking versus long-term thinking. Here we think about using probabilities for prediction, foreseeability to a certain extent. And this happens in risk assessment, risk prediction, because we know that risk assessments to a certain extent, the positive predictive value is low. It's difficult to predict, we know that. But what we try to do is to recognize that in the short term, we have a certain aspect we need to focus on, but we know things change constantly. That's the uncertainty that I talked about. So therefore, we are constantly thinking about the changeable aspects in the environment, employment, relationships, accommodation, finances, illness relapse, etc., which can increase the risk of certain things happening, substance use, etc., etc. Because as I mentioned earlier, we are on a decades-long journey with the patient, and we know that this probabilistic thinking for foreseeability is very, very important. And finally, strategic thinking. What we try to do here is to think not as just diagnosis and treatment, but someone who formulates the case, as I mentioned earlier, factors in formulation, and then to implement a strategic management plan based on clear domains. And those domains are usually we think about, I've covered this in another video as well, how to think like a psychiatrist and inside the mind of a psychiatrist, so on this channel. Basically, what we're doing there is thinking about risk and setting first. Then we're thinking about clarifying the diagnosis by constantly taking these hypotheses, falsifying, and gathering information. Then we think about treatment, biopsychosocial, cultural, diet, lifestyle. Then we think about long-term treatment, which is relapse prevention, drug and alcohol relapse prevention, and psychosocial aspects, finances, relationships, accommodation, vocation, and medical legal aspects. Then we think, what are the barriers for implementation? They could be patient factors, they could be clinician factors, they could be system factors, they could be treatment factors. And then we think, what's the prognosis here? Short-term versus long-term. And that's the strategic thinking that we pull together. And this is a crucial aspect for a psychiatrist to develop overall. These 12 skills, in my opinion, are absolutely crucial, are essential for a psychiatrist to have, to develop for good outcomes in relation to patient care. But I'd be interested in your thoughts as well. So if you think there are skills, additional skills, please let me know in the comments section. Thank you so much for watching and giving up your time and spending that with me. And I really do appreciate that. I look forward to seeing you in another edition of Hub Bites. Until then, take care and stay safe. Bye-bye.